The following podcast is part of a certified educational activity titled Master MDS for Enhanced Patient Care, Modern Advances with Standard and Emerging Risk-Adapted Treatment. Access the entire activity and complete the post-test at peerview.com/GKY860. Downloadable slides and practice aids are also available.
My name is Guillermo Garcia-Manero from MD Anderson, and I'm super happy and honored to be here with Dr. Maria Diez-Campello. So Dr. Campello is the leader of the Spanish MDS group that I think is like probably the most active group right now in the world, representing a country and really a great colleague and thought leader. And also with Dr. Sangeeta Benagopal from the University of Miami, that is also an expert on MDS and related conditions. It's really an honor to be here with both of you.
This field is kind of an evolution, and indeed, actually, I believe that there is a meeting in the next few months, early in 2026, where both the WHO and the ICC groups are trying to get together to see if we can develop a new classification for this disease. Like, we don't have anything else to do. But the bottom line is, as you know, there's been kind of a transition over the years in terms of how we call this disease, what type of parameters we use to classify it. I think when I look at WHO versus ICC, the main thing is this kind of cutoff of more or less than 10% blast. And I'm quite open saying that I don't believe that AML should be considered more than 10% blast. These diseases are totally different. They have totally different behavior, and therefore they likely need a different approach. What is really been a game changer is this issue of incorporating molecular data in our understanding of these patients. And by that I mean, around 10, 15 years ago, we started using NGS data. And then finally, a couple of years ago, we got this IPSS molecular that we all use. And this actually has really transformed our view of these patients, how we prognosticate them, and hopefully in the future also how we conduct clinical trials. Now, I think that, I don't know if this happens in other diseases, but in MDS, this is actually quite important. We have this kind of separation, this dichotomy between what's happening in terms of clinical trials, what we would like to do for our patients, and maybe what happens in the real world. These patients are older, they may have comorbidities that incidentally we think more and more are part of the disease. But the reality is that when people do this kind of real world data or looking at electronic health records, we see actually that only a fraction of these patients are treated. And this is actually heartbreaking to me, because we put quite a bit of energy in developing these compounds that we think in the right context can be quite effective, yet this may not always translate, at least in the United States, to the full population of those patients. So for instance, you see here that in first line of almost 1,500 patients, only a third of them went on to receive second line therapy. And this is kind of an issue because we now have second and third line and even targeted approaches for our patients. And then the other very interesting thing is that, and this probably relates a lot to these ESAs that we have used for so many years, is that we have these drugs, we use them, they actually don't really work in a significant fraction of patients, but they've been with us for a long time. But then somehow we have some inertia where we don't really move to the next step. So that's actually fascinating, particularly as you will see through the next 3 talks, that the therapeutic armamentarium for these patients is really evolving. So we really need to be a little bit more assertive when it comes to our treatment options for these patients. So this is like a slight short introduction. So what are the goals for today's presentation? So hopefully we'll be able to convey kind of a modern understanding of MDS. We're going to be talking about frontline, first-line therapy for patients with low-risk MDS and anemia. We're going to be talking also about new clinical trials in high-risk MDS, and hopefully like a holistic approach of how we, the three of us, see the treatment of this disease. Before we move into the actual talk, we want to acknowledge HealthTree Cure Hub. It's actually an innovation that powers life-saving research, and it's actually supporting quite a bit of what we're going to be presenting today. And with that, we're going to start with the first talk, and we're going to be discussing in my part low-risk MDS, and we like to use a clinical vignette to basically have a conversation around what we're going to be discussing. So this is a gentleman that presents with low-risk MDS, and some comorbidities, so 78, has some renal dysfunction, some coronary artery disease. Let me start here by saying that in the past, we thought that these were kind of things that happen as part of aging, meaning, you're older, you have coronary disease, you have MDS, but we're starting to understand that some of these comorbidities may be actually somehow related to this myeloid clone. So it's possible that the coronary disease that this individual has may be somehow also related to his MDS. He has some cytopenia, has anemia. You perform a bone marrow exam. Of course, that's perhaps the very first step that doesn't happen universally. Sometimes these older individuals are not evaluated to the extent that they should. And in that bone marrow exam, you see erythroid dysplasia. You see these cells that we call ring sideroblast, occupying 25% of that particular compartment. This in itself actually is fascinating because for us, this is trivial. This just requires an iron stain, but in some countries, actually, there is no even expertise in doing this kind of test. And the patient has a low percentage of blast. Your chromosome, that is still a key part of how we evaluate these patients, is normal, and this patient with low-risk disease is quite crucial to exclude that the patient has a del5q alteration because the treatment of that is quite specific. And then you run your next-generation sequencing assay that most of us now have in our clinics. And what you see is that this patient has the most frequent mutation in low-risk MDS. That is this SF3B1, very important splicing factor. Now, what you see is that next to it, it says K700E. So this is the most common codon mutated in this disease, and is particularly associated with a more benign prognosis. This is like the true phenotype of low-risk ring sideroblastic anemia with a significant VIF. I say that because not all SF3B1 mutations are as benign. Some of them actually are seen in the context of more aggressive disease. And then very important, this patient does not have a TP53 mutation. This actually will be kind of not that frequent in this group of patients with low-risk disease, but it's very important to evaluate. No targetable mutations such as IDH1 or 2. Patient is some aspirin because of the coronary disease and is transfused 2 units of red cells every 3 weeks for 4 months. So this patient is clearly transfusion dependent, is fatigued. This is an issue that we have been discussing actually with Dr. Diaz-Campello yesterday in a couple of meetings in terms of how we assess symptom burden, what is the impact of those, can this be actually some type of tool that we could assess in clinical trials. And then for fun, this patient actually has a serum EPO level that is kind of the limit of what will be threshold of an EPO where ESAs may or may not work very effectively and is clearly anemic. So the question here now is, in 2025, at the end of this year, what are the goals of therapy? And how important actually is this transfusion burden? And this to me is something that is changing dramatically, and I hope that I can convey that over the next few minutes, because we've gone from a situation where we just wanted to stabilize hemoglobin levels, then we wanted to decrease transfusions, and now, as you will see soon, we're starting to ask the question, is it possible that we're changing the natural history of this disease? In other words, are these patients living longer because of this intervention? So here then, the question is, what will be the first-line option for these patients? And is there a role, for instance, for luspatercept in this group of patients based on this COMMANDS data that we're going to be discussing next? Now, what is really clear is that this RS-positive patient with SF3B1 K700E is like a really clear case where that data will apply. The question that we will also be trying to address through the next few slides is, what will be our approach if the patient was RS negative, meaning no ring sideroblast, no SF3B1 mutation? We will be using the same type of approach for him or not. So first start with some slides that I have to disclaim I never understood, and now they're starting to make sense to me. That is the impact of anemia and transfusion dependency in the disease itself. So as you see, these slides are like the original one, 2007. Some of these papers around this time. And I couldn't understand them because in my mind, it was all associated to the risk of the disease. So if you had more or less worse disease, then but here what these investigators were showing is that this had independent value. And I could not kind of dissociate one from the other. But this is actually becoming very clear, that there is something about this need of transfusions and the transfusion burden as a really independent prognostic variable in patients with this disease. So this is now becoming an issue because improving these transfusions not only is fundamental for the well-being of our patients in terms of quality of life and other issues, actually it may be what results in improving their survival. So I think this is actually still, so many years later, a very important concept that now maybe finally I'm starting to understand. The other issue, and this is data from Dr. Diaz-Campello, is the burden of this process. And I work in a very large hospital in Houston, and I can tell you this is with the largest blood bank in the world for a single center. This is a huge deal for us. Patients spend there like all day. You have to type and cross these patients. And then you think these things are these transfusions are benign and not costly, but they have significant cost, and they're associated with significant toxicity. So if you work in a big center like mine, eventually you get called weekly for this patient who is heavily transfusion dependent, that now has TACO and needs to go to the ICU because of some complication, etc. So there's a significant cost for these individuals that tend to be elderly, having to come, one time a week or sometimes more than that for this type of care. And as you see in this slide from Maria, that I think is actually quite important, it's not only an individual issue for the patient itself, for the patient, right? These are individuals that are older, so they depend in the family, etc. So there is a significant burden to these patients. And I think the field is moving into more effective therapies for anemia. We're actually also moving into these oral hypomethylating agents that hopefully will also help a little bit in this particular issue of your dependency to the center, which is something quite important. There's been a little bit of in my opinion, controversy in terms of these NCCN guidelines. And I was listening that maybe there's some European and international guidelines. But I used to serve on this committee until a few weeks ago. And the bottom line is what you will see when you go to the NCCN guidelines is you have this group of patients with RS-positive disease with this SF3B1 mutation. By the way, not only the K700T, I was just mentioning that mutation is associated with a particular good prognosis, where the indication based on the COMMANDS data, and we're talking about first-line therapy, is obviously luspatercept. And then you will see that there is an option for imetelstat, a telomerase inhibitor that actually Dr. Diaz-Campello helped very much develop for patients with an EPO level more than 500. And I emphasize this because on the COMMANDS trial, we excluded patients with EPO level more than 500 because we were comparing luspatercept with an ESA. So there may be a small group of patients where you could consider the telomerase inhibitor upfront if their EPO level is elevated over 500. Then you have the group of patients with RS-negative disease. And here, the guidelines are not that clear. Remember, actually, that it is quite infrequent to have a high EPO level, meaning high over 500 at initial presentation. That's actually uncommon. It can happen. And there, if your EPO level is less than 500, you have an option of using luspatercept or using an ESA. And here, you will go through the data and you will make your proper decision. Now, if your EPO level is more than 500, this gets a little bit complicated. These guidelines talk about ISTs, meaning kind of a plastic anemia-based therapies. I have never done that, actually. I don't know if Dr. Diaz-Campello or Dr. Venugopal do that in their practices. So, sometimes these guidelines have these experts, but I'm not sure actually how they come with these conclusions. For us here, the role will be maybe, imetelstat based on against the IMERT study. There's significant use of hypomethylating agents in low-risk disease in North America, and there may be other opportunities for these patients. I think what you remember here is RS positive versus RS negative. And then over the last few years, we've been working on developing these drugs that inhibit TGF-beta pathway that actually through some kind of experiments that were related to some other pathway, actually looking at bone metabolism, indicated that if you block TGF-beta, you may actually increase what they call late-stage erythropoiesis. It's actually a very interesting concept. So the idea here is that there's not like a direct inhibitor of this pathway. What you do is bind the ligands that activate the pathway. So if you trap them, and that's what the luspatercept is an antibody that will go and trap those ligands, then you have less signaling through this pathway. And this actually eventually results in enhancement of late erythropoiesis. Why understanding the mechanism of action is important is because it will give us at some point some ideas in terms of how we combine different drugs that may work in different stages of erythropoiesis. Now, the COMMANDS trial was a very large international study. Dr. Diaz-Campello and myself were part of this study, so it happened basically all over the world. In my opinion, extremely well designed, and I say that because there were a lot of pre-planned analyses that now are giving us really important results. So many times we do these phase 3 trials, and then later on we say, oh, let's look at this, let's look at that, but these are actually post-op analysis that we're just doing because we have some idea. Here, actually, when we designed the trial with a statistical rigor, we were thinking we were going to measure their output at 12 weeks, at 1 year, at 1 year and a half. We're going to look at the survival, and this was all pre-planned. So here, this slide, you see the analysis of this COMMAND study, indicating basically that when you look at the response of luspatercept compared to epoetin alpha, that was the ESA that was used on this trial, you basically are doubling that. So it's like 60% versus 35%. Now, what this slide doesn't really clearly show, that I think we need to emphasize, is that in this study, we had a dual endpoint. So to be called a responder, you had to be transfusion independent for that period of 12 weeks. But in addition, you should have an increase in hemoglobin of around 1.5 grams. So this is quite important. So a responder was someone that had a significant increase in hemoglobin plus that duration of transfusion independency. This was actually the first study ever conducted with this kind of, what I think, more solid response criteria. Of course, having a response is great, but you want to look at the durability of this response. And here you see data that I had the opportunity to present at ASCO a few months ago, looking now in significant long follow-up at the duration of these responses. And if you go, for instance, in the table, I think I can show it here, I'm not sure, yeah. You will see it's 150 weeks versus 95. So basically, you're almost giving an extra year of response. And remember, response is the increase in hemoglobin plus the transfusion dependency for those patients receiving luspatercept versus those on the ESA. So this actually is quite a significant, remarkable result. And then with this long follow-up, what we see is that now a third of the patients actually are still responding if you look at those that are more than a year and a half on therapy. So quite remarkable results when you use this compound as a first-line agent. Now, we had planned a secondary endpoint to look at survival. And I remember when we were designing the trial, people say, why would you be interested in looking at survival in a study of low-risk MDS with a drug that, quote-unquote, does not have anti-leukemia activity? This is actually very interesting because people now, traditional leukemia, we want to get rid of the cells, get rid of the mutations, etc., and we associate this MRD with survival. But in MDS, this may not be the case. First, the stem cell is always affected, so it may not be able for us to actually do that. And there may be some other factors that affect the survival of our patients. So this is, again, a pre-planned analysis looking at the survival of the COMMANDS trial. So this was first presented at ASCO, later by Dr. Santini at the meeting. And what you see is that now we are starting to observe a separation on the survival of these patients with kind of across here around, I think it's like around between 20 to 30 months. That is the expectation, actually, because remember, these are patients with low-risk disease that you don't think they're going to progress or die that quickly from the disease. And now these curves start to separate. So this is really fundamental signal because this is for the first time in a phase 3 trial of an intervention like this, kind of aiming at anemia, where we're starting to see an improvement in survival. And I think the question for us is, how does this happen? Because again, there is no modulation of this mutation, so there's no anti-leukemia activity of the compound. The molecular burden of the disease is not going to change. So it's actually quite a robust, also pre-planned prospective analysis looking at RNA-seq pathways that are modulated by luspatercept in this trial. And you see prototypical pathways affected like cytokine modulation, of course TGF-beta, but also other pathways that may affect cardiac function and other kind of systemic processes that could be involved in the improvement in survival of these patients. So I find this data really important, and we're really working hard trying to come with a good analysis that will give us some idea of why this happens. So I think this is actually fundamental. Now, Dr. Diaz-Campello a couple of years ago published what I think is a fundamental paper showing a little bit of the same with lenalidomide at low doses in del5Q minus MDS. And so this suggests actually that we could intervene in first-line therapy in a specific subset of patients and start thinking about prolongation of the disease. We're not talking about cure, but really making these patients live longer. So we are very excited about this. Now, the other thing that is really interesting from this COMMANDS late analysis, and again, not really expected because we were thinking about these drugs at the beginning just as pure modulators of transfusion burden, but we're starting to see that there is an impact on the rate of transformation from low risk to high risk disease. Now, if you look at the cause of death in patients with this disease, number one is infection, number two actually is a cardiac event. Around 20 to 30 of these patients, by our data historically, will go and eventually transform with time into high-risk MDS, and some of them maybe to acute myelogenous leukemia. So what we're starting to see here is that the rate of transformation from the low risk to high risk appears to be attenuated by the therapy. This is also fascinating. Again, we're modulating with this luspatercept some of these inflammatory pathways, and the question is, you have this mutation, those trigger some type of inflammatory cytokine. What do these drugs do to modulate that effect, and how that actually may be slowing the progression of this disease? That's actually also a very important aspect of the analysis from the COMMANDS trial. Now, this is some data that is going to be presented at the meeting, looking actually at whether this is something that you see also outside the context of the COMMANDS trials or real-world data, and then this idea actually of should we start using these compounds earlier in the course of the disease before they fully become transfusion dependent. You know, to design a study like COMMANDS, you have to be transfusion dependent so you can then measure the transfusion dependency. But the reality is that may not be the optimal way to use these compounds. And indeed, for instance, the most advanced label is in Japan, where basically our colleagues there can treat these patients with anemia without really having this factor of transfusion dependency. So this is data that will be presented by Dr. Santini, looking at this issue of patients that are ESA naive early in the course of the disease. And what you're seeing there is that those patients may respond in close to 90% of the time. So an early intervention, similar to what Dr. Campello did with lenalidomide, may be quite effective for this group of patients. And this is being actually evaluated on a trial that is ongoing, and many of us are on that study called the ELEMENT trial. I think, I don't know what the answer of the study is going to be, but here basically what we're doing is in transfusion-independent patients. Now, they have to have some degree of anemia, I think hemoglobin less than 9.5 or something like this, if I recall correctly. Patients are now randomized between ESA and luspatercept, trying to see what happens if you intervene early. So I don't know who is going to win here, but I think the answer is going to be extremely important for us because it's going to really tell us in a prospective way if starting therapy in this group of patients with some degree of anemia but not transfusion dependent yet will actually change the natural history of the disease. My hypothesis will be that it will. I don't know which drug will be better. And I think that we're going to see robust transfusion responses that may last actually for long period of time. So this may be a study that really changes our approach to the disease. So hopefully we'll get this data time soon. The next question on this individual is what are the response benchmarks? I mean, what is this that you will be doing to assess the response? Now, we talked that in the COMMANDS trial, there was an increase in hemoglobin and this transfusion independency. So that still, I think, is really fundamental. The other issues are we asking for more? The quality of life, the improvement in survival. So that is something that I think is going to be part of the discussion more and more when we offer these compounds. Just a couple of practical issues in terms of how these drugs are dosed. This is actually quite important. And I don't know in Europe or in other countries, but in the United States, we still have to educate our colleagues a little bit. You start with this dose of 1, then you go to 1.33 after a couple of doses or when needed, and eventually you can go up to a dose of 1.75. Now, there is also an interesting concept that is the higher the hemoglobin, the better your patient is going to do in terms of overall survival. And this is actually data that will be presented by Dr. Su also at this meeting. So those individuals that get responses with over 10 grams of hemoglobin, they do significantly better than the others. And lately I've been telling this kind of anecdote, a pseudo joke, but it's actually a true story. where a patient of mine who's on the ELEMENT trial is asking me, doctor, what is your hemoglobin? And I said, okay, don't want to share with you. I said, no, I really want to know. So I tell him, well, it's kind of, I do a CBC once a year. Actually, it was 15 grams the other day. And then he is like, why you kept me at 11.5? In other words, why are we staying at these hemoglobin levels where I'm still anemic? So this is actually quite important and is now being evaluated in a number of clinical trials. So this again will be presented at this meeting, was first introduced by Mateo de la Porta at IJA, and it's this Maxilo study, that the idea here is to start with the luspatercept at the full dose. And that is associated with an increased rate of response. My issue with this actually is the threshold. Like, I would like the authorities to allow us to go over 12, maybe over 12 and a half. So we'll see what happens with this data. And with that, I think we're gonna move it to Dr. Diaz-Campello from Salamanca, who's gonna be talking about sequences in this disease.
Thank you. Good morning. Good morning, everyone. Let's move to the next topic, trying to address the best sequence for the treatment of this patient. Here you can see another patient recently diagnosed and diagnosed with severe anemia. Generally, we try to treat early, as Guillermo commented, at least in Europe, we try to treat the patient before transfusion dependency, but sometimes the patient is diagnosed with transfusions and we don't have enough time to treat early. This patient is 72 years old, low-risk MDS with this phenotype, no ring sideroblasts, SF3B1 wild type, no steatoblasts, and normal karyotype. This is the typical patients with low-risk MDS with severe anemia at diagnosis that require transfusions from the beginning to red blood cell units every month for 5 months. Initially, the treatment should be started, at least in Europe, with hypo-alpha, because even that we have approval for luspatercept, not all the countries are allowed to use it in ring sideroblast negative patients, and the patient receive erythropoietic stimulating agents and at the higher doses for 10 weeks. After that, the patient did not have an improvement in hemoglobin, no rise of hemoglobin levels, and no reduction in the transfusion needs, so the patient is still stable after 10 weeks of treatment. The discussion about this case is probably that the definition of this patient, is this a patient ESA refractory, or we should treat more time with the drug? What are the next steps regarding treatment, and what factor can allow us to identify the best treatment between availables for a second line in this patient regarding luspatercept and imetelstat? Also, we can discuss about the endogenous EPO levels, because as you can see here, the endogenous EPO level at this time is pretty high, more than 500, and we know that the results of different treatments with these levels are going to decrease and be shorter. Nevertheless, we have to choose an option. Probably this patient should be better used with luspatercept, as Guillermo previously commented, but this patient was not allowed to be included in COMAS trial due to the high endogenous EPO level, and probably imetelstat could be an option in first-line treatment due to the fact that it's not eligible for this elevated endogenous EPO level to receive ESA. And alternatively, see if the patient has received luspatercept for any way, it should be able to receive after that imetelstat. Let's review this discussion with you. Here you can see the first question, the definition, the clinical definition for a patient that is not responding to ESA. The first thing that we have to take into account is that the patient should receive the optimal dose of ESA, higher doses of hypo-alpha or darbepoetin alpha for at least 8 to 12 weeks, and we should confirm that the patient did not have a depletion in iron stores, B12 or folic acid. And if the patient is treated with this condition for at least 8 to 12 weeks and did not increase hemoglobin level or don't presented a reduction in the transfusion requirements is, of course, a patient not responding to ESA, so we should to discontinue for the treatment. Interestingly, in this patient, we have also a predictive factor for no-response. We know that when the patient is in transfusion dependency, response to ESA is decreased, but even better, these responses are completely avoid, probably with this other predictive factor that is endogenous EPO level. When the patient is with a greater endogenous EPO, more than 500, the probability of failure is pretty high, near 100%. So probably this is not the best candidate for ESA, and as it expected, the patient failure to the treatment. Here you can see the current NCCN guidelines with options for second-line treatment in patients with ring sideroblast negative. Here you can see that it's also divided according to endogenous EPO level, and as Guillermo previously commented, immunosuppressive therapy is very uncommon in this subset of patients. I've never used in my clinical practice for a long time because the majority of these patients are not candidates for this treatment, so it's not an option probably in the majority of the patients, but we have these available drugs in this context, imetelstat, according to the IMerge trial, and luspatercept. Luspatercept also is the second-line treatment for patients with ring sideroblasts or SF3B1 mutated disease due to the to the Medalist clinical trial, and imetelstat is also an option in this setting. So we have to choose between one and other option. Nowadays, you have that Medalist trial was focused in patients with ring sideroblasts or SF3B1 mutated patients after ESA failure, and we know that the overall results are near 40% of the patients with transfusion independency. Nevertheless, we can analyze, when we analyze the overall treatment period, we identify that some patients that continue treatment after the first 24 weeks with initial non-response to the luspatercept treatment, the patients continued because they presented a benefit, and they are able to reach even a transfusion independency benefit and also a reduction in transfusion burden. So the idea is that if the patient is not reaching a transfusion independency, we probably should keep on treatment because the patient could achieve a later response that benefit for the patient. So if we analyze the entire period of the treatment, we confirm that the achievement of transfusion independency is around 50% in the overall population, and interestingly, for patients not reaching transfusion independency, there is a great amount of reduction in the transfusion burden, as you can see here, and near 50% of them are going to reduce more than 50% of the transfusion requirements. So it's important that if the patient is not reaching transfusion independency in the first 6 months, we can and tolerate well the drug that is expected because of no adverse event is associated with this drug and no severe adverse event, we can continue in order to try to obtain a later response or even a reduction in the transfusion burden. And here you can see, when we analyze all this data, that the median duration of this transfusion independency is very prolonged, near 2 years, as compared to only 20 weeks in patients receiving placebo. So the patients will remain stable and in transfusion-free for a prolonged period of time. This is for patients with ring sideroblasts and with a very good safety profile. Interestingly, we are currently participating in the Maxilus trial, as Guillermo previously commented. We initiate the dose of luspatercept at the highest dose, that means 1.75 milligrams per kilo, and the results in the second-line setting that is presented here, and it's going to be updated on next Monday during this meeting by Dr. Zeidan, are amazing because they are increasing the rate of responses. The comparison for this trial is the results of the Medalist trial, and you can see here that up to 65% of the patients are going to respond to the drug initially, And you have to take into account that here the primary endpoint includes also a hemoglobin rise of more than 1 gram per deciliter, so it's much more strict than the Medalist clinical trial. Interestingly, the responses are sustainable over time, and you can see here near 50% of the patients reach transfusion independency for more than 2 weeks. And this trial also includes patients with no ring sideroblasts that are not allowed in the Medalist clinical trial. And in this population, we achieve with this higher dose from the beginning 30% of the responses, 33%. So this is, I think, very interesting because with this very good safety profile could be also an option for ring sideroblast negative patients. The other available drug in this context is imetelstat. As all you know, it's a different mechanism of action drug for these patients, and this drug is targeting malignant clones due to the fact that they have an upregulated telomerase activity. The idea with this drug is that induce apoptosis in these malignant cells and is able to potential recovery for normal hematopoiesis. This drug has been approved by FDA and also by European Agency for patients after ESA failure with and without ring sideroblasts, and is available only for American patients because in Europe it's still pending for commercialization. Here you can see the main results of the eMERGE clinical trial, including patients with and without ring sideroblasts, and included patients with a very high transfusion burden. And you can see here that 40% of them reach this goal of transfusion independency that remain stable over time. The median duration of the transfusion independency for this primary endpoint was around 1 year. And we identify that if the patient is still in transfusion independency after 6 months or even after 1 year, the median duration of this transfusion independency is very prolonged. And here you can see that patients that are still in transfusion independency after 1 year has a expected median duration of transfusion independency of near 2.5 years. So this is amazing for the patient. We can identify the benefit of this treatment in different populations, and you can see here the role of this drug in treatment-naive patients due to the ESA, due to the fact that these patients could have increased levels of endogenous EPO. And in this setting, in patients not eligible to ESA, we have only 43 patients, but the results are promising because more than 50% of them are going to reach the transfusion independency. Regarding the patients after ESA, we can see that all these patients respond, and the responses decrease according to the endogenous EPO levels, traducing that probably when we treat the patient early, as we have commonly previously, the results are going to be even better. And these results decrease according to the increase in the endogenous EPO level for all the times for the transfusion independency. And regarding the type of failure of ESA, you can see here that the most responders to imetelstat after ESA failure are those that initially responded to ESA. Also, refractory patients response a little bit poor, and ASA ineligible, as we can comment on it. And interestingly, in this trial, we have an extension phase in which some patients with luspatercept treatment before imetelstat can be included. And here you can see that the results are pretty similar to those previous, and up to 1/3 of the patients can respond to imetelstat after luspa failure. So probably this drug should be put before imetelstat due to the fact of the hematological toxicity that this compound have. Here you can see the long-term follow-up update for the clinical trial that is going to be presented by Dr. Santini in a poster presentation tomorrow afternoon. And as you can see here, a trend towards to better outcomes are expected with the patient receiving imetelstat. This study was not powered to identify these differences. It's not statistically significant. There are only a few months of benefit, but it seems to, like Guillermo presented in the luspatercept trial, probably decrease in the progression to higher entities. The overall results in this trial was associated with the achievement of transfusion independency and hemoglobin rise, probably according to the response to treatment. And we are thinking about that the patient is responding, probably has better outcomes due to the fact that we are free of transfusions and all these complications. In our patients, according to the label, we decided to start with imetelstat, and we need to know what happened with this drug in this context, because as I can previously comment, it's a completely different drug in this setting, and toxicity is also completely different from luspatercept. We expected that the majority of the patients are going to develop adverse events related to hematological complications, and as you can see here, grade 3 and 4 for thrombocytopenia and neutropenia are present in the majority of the patients. Nevertheless, two messages for your information. The first message is that these cytopenias generally are of shorter duration. You can see here 1.5 to 2 weeks for resolution, and the majority of them are going to be resolved before the next cycle. So, in the majority of the cases, the patient, when come for the next cycle, is recovery for these cytopenias. And another important message, the second one, is that these cytopenias are not translated in clinical consequences for the patient. That means that the patient did not have an increase in bleeding, infections, or other complications due to these cytopenias. They are only numerical issues and not clinical issues for the patients. Importantly, we have to start with the current dose, that is 7.5 milligrams per kilo, intravenously over 2 hours every 4 weeks, and we need to premedicate the patient with these two compounds in order to avoid side reactions. Here you can see that if the patient develop grade 3 and 4 adverse events, we need to delay the dose if the patient don't have a recovery for the next cycle, and of course start with dose reduction with these two types of reduction. First reduction at 5.6 and the second one 4.5. Importantly, you need to administer at least 6 doses in order to try to wait for response. Only you have to discontinue if the patient presented unacceptable toxicity, or if the patient after the 6 doses did not have a decrease in the transfusion burden. But don't discontinue if the patient presented adverse events related to cytopenias, because as you can see here, and we are going to see in the oral presentation next Sunday by Dr. Seidan, the presence of cytopenias in terms of platelet reduction and neutrophil reduction is associated when it's present during the first 2 cycles to response of the patient, like it happens with lenalidomide in the LEL5Q setting, probably due to the fact that probably the bone marrow is being removing for clonal cells and started to repopulate with normal cells. You can see here that those patients with a greater reduction in platelets and neutrophils count are those that are going to be responding according to different variables: hemoglobin rise, transfusion independency, and hematological improvement. So if the patient is developing this cytopenia, we have to try to keep the patient on treatment with safety recommendations according to dose delay and dose decrease. Here you can see the different options. Luspatercept remains the standard of care for second line in patients, especially with ring sideroblasts. Imetelstat is also a very good option. We have to take care with this hematological toxicity, and we have to pay attention with dosing and safety in order to not avoid different treatments for sequencing from first line to second line. And that's all. Thank you very much.
Hi everyone. So now I'm going to talk about high-risk MDS. I know we have made a lot of progress in the lower-risk MDS. However, we are still struggling with the optimal treatment options for high-risk MDS. Now we are going to review the evidence of treatment in higher-risk MDS. So Jennifer Rivera, she's a 65-year-old lady of Cuban origin. She comes to my clinic with progressive weight loss and worsening anemia and low platelets and neutrophils. She has good organ function, has good performance status, goes to Pilates every other day, and we evaluated her for pancytopenia. What is the reason? So the bone marrow biopsy shows 10% blasts with monosomy 7, ASXL1 mutation. Note there is no TP53. And by IPSS-M and IPSS-R, she is higher risk MDS. So she's actively considering stem cell therapy as part of her treatment plan. And she is asking me a few questions. Do I need treatment before stem cell treatment? Or what is if stem cell treatment is not an immediate option, what are the other options available? So stem cell therapy, clinical trials, hypomethylating agents, and targeted agents are the recommended options for first-line treatment in patients who are eligible for stem cell transplant in higher-risk MDS. And azacitidine ivosidenib combination in selected patients, it's about 5% of the patients who have IDH1 mutation. Those patients are treated with azacitidine ivosidenib, or clinical trial, which is always the first option, followed by stem cell transplant, and HMA plus or minus venetoclax and high-intensity treatment. So in 2021, there were two sister papers published in JCO. So these are two biological assignment trials. So this is the next best evidence other than the randomized control trial. So in these two papers, what happened was they assigned the patients according to the donor availability. So those patients who had the donors immediately were assigned to the donor arm, and those who did not were assigned to the no donor arm. So the no donor arm were treated with hypomethylating agents or best supportive care. So in this paper, this is a study by BMT CTN network, and what they did was, if stem cell transplant is an effective option in MDS, because stem cell transplant in MDS, in higher risk MDS, is often underutilized, and many of these patients do get treatment after treatment without even seeing a transplant physician. So as you can see, there were 384 patients who were enrolled in this study, and 260 were randomized to the donor arm, and 124 patients were in the no donor arm. And primary endpoint was 3-year overall survival. As you can see, the donor arm is represented by the blue line, and the no donor arm is represented by the orange line. You could see that there was an absolute improvement in overall survival in the donor arm, and this was true across all subgroups that were analyzed. So make sure that we should ensure that all of our patients who are high-risk MDS and who have good performance status do see us leukemia physicians and the transplant physicians at the same time, so that these processes can happen in parallel. Now the next question comes, okay, while this patient waits for transplant, do I need to do something, or is there any other medication that I need to be using? So this is a study from the German group. This is also kind of the similar setup as donor and no donor arm. However, this study has 4-month lead-in period with azacitidine. Azacitidine followed by reduced intensity stem cell transplant. So the patients 81 patients were in that arm, azacitidine followed by stem cell transplant, as opposed to continuous azacitidine in about 27 patients. So stem cell transplant after azacitidine significantly improved the event-free survival. The overall survival did favor the stem cell transplant, but did not reach the statistical significance. However, the most important point to note was the investigators looked at the patients who were in the 4-month lead-in period, and in which the 33% of the patients did not proceed to stem cell transplant. The reason being, half of these patients dropped out because of disease progression, and half of these patients could not go to transplant, or there was a delay in transplant due to infectious complications. So the take-home message from these two studies are stem cell transplant does remain the only curative option. Azacitidine does improve survival but does not prevent inevitable progression of the disease. And bridging with multiple azacitidine cycle does risk the losing the transplant opportunity. So the next question we need to ask ourselves, or I ask myself, is like, okay, this patient has 10% blast. Do I just wait, or is there any utility in downgrading this patient's blast? So this study was published in Blood last year. Does IPSS-R downstaging before stem cell transplant improve the prognosis? So this is an EBMT study, and you could see these three curves, and the untreated, which is represented by the red line, chemotherapy, which is represented by the blue line, hypomethylating agent by the green, and the purple with the other. So these are the curves are showing same number of blasts, improving number of blasts, and blasts progressing on treatment or no treatment. So you could see that in the same number of blasts, you could see the first curve, which is the red and the green curve, are just the same, and other, which is the blue and the purple curve. So you could see that the survival is just the same in untreated. If the blast number is the same, both it's improved in both untreated as well as for hypomethylating agent. So improving, in blasts that are improving, you could see that the blue line tops over the rest, and the blue line is represented by the chemotherapy. So the change in bone marrow blast is prognostically relevant mainly in the chemo-treated patients. And you could the next curve is if the blast number is increasing. Untreated patients does have better survival compared to the rest of the treatment options. So there is limited benefit to IPSS-R downstaging or reduction of bone marrow blasts after chemotherapy, and there is no benefit for hypomethylating agents or other treatments. So the point of this discussion is if your patient is ready to go for transplant, do not delay transplant for any other therapy. Just get the patient to transplant, and that remains the only curative option in high-risk MDS. So what for non-stem cell transplant eligible candidates with higher risk MDS, what are the treatment options that are available? So clinical trial remains the first option, and azacitidine is the category 1 recommended by the NCCN, and decitabine plus or minus venetoclax, oral decitabine cedazuridine plus or minus venetoclax. And for a selected subset of patients, azacitidine with ivosidenib or olutasidenib is a category 2B recommendations for these patients who are not transplant eligible. So my patient, Ms. Rivera, she is considering enrollment in a clinical trial because, as I said, she is a patient of Cuban origin, and they do have a less of a donor pool compared to the Caucasian pool. So this patient is interested in pursuing a clinical trial. So what type of treatment should be pursued given her high-risk status? Is pursuing treatment with a BCL2 inhibitor still an option? So what is the rationale for combining BCL2 inhibitor with hypomethylating agent? I'm not going to discuss about the mechanism of action of venetoclax, just to say a short blurb, which is it is a BH3 mimetic, and it is a selective BCL2 inhibitor and acts on the apoptotic pathway. So what azacitidine and venetoclax acts synergistically because azacitidine primes the cells for the cell kill by the venetoclax. It does upregulate the pro-apoptotic genes, and the venetoclax inhibits the anti-apoptotic genes, enhancing the cell kill by this combination. So this is the study that all of us were eagerly waiting for, and this is phase 3 Verona study. This is a combination of venetoclax with azacitidine in higher risk MDS. 500 patients with newly diagnosed high-risk MDS were randomized in a 1-to-1 fashion to venetoclax 400 milligram daily or given on day 1 to 14 with azacitidine as a 7-day cycle. And the control arm was with azacitidine monotherapy. So the primary endpoint of this trial was overall survival. Responses were assessed according to the IWG 2006 criteria. The key secondary endpoints included overall response rate, which is a combination of complete remission, partial response, and marrow CR. Overall hematological rate, red cell, and platelet transfusion independence rate were the other key secondary endpoints. So no significant difference in overall survival between the Win-AZA combination as opposed to AZA monotherapy was observed. As you can see, the overall survival was kind of similar in the combination arm as opposed to the AZA arm. This was presented in this year's SOHO by Dr. Garcia-Manero. So the overall response rate, even though the survival was not significant, the overall response rate was higher in the combination arm as opposed to the AZA monotherapy arm. As you can see, there was the overall response rate was 76% as opposed to 57% in the AZA monotherapy arm. And you could see the overall hematological improvement and transfusion independence was higher in the HMA venetoclax arm as opposed to the AZA monotherapy arm. And this is the subgroup analysis. You could see that when AZA arm was favored in most of the subgroups except the baseline bone marrow blast of less than 5%. And you could see that almost all of the ASXL1 mutation, venetoclax is ASXL1 mutation, EZH2, RUNX1 mutation, they are all sensitive to the HMA-Ven arm as opposed to the AZA monotherapy arm. So there is an updated ASH abstract that is being presented by Dr. Garcia-Manero in this as an oral. Subgroup analysis did show a trend towards a higher overall response rate in the HMA-Ven arm in patients with 5% blast and mutations in ASXL1, TP53, or RUNX1. And marrow CR with hematological improvement, which is a near complete response, was higher with HMA-Ven arm as opposed to the AZA monotherapy arm. So the one I discussed was the prospective study. This is the retrospective analysis. This is going to be presented as an oral abstract on Saturday. And this is 19 U.S. academic centers that evaluated patients with higher risk MDS treated with frontline HMA venetoclax or HMA alone. As you could see, the survival outcomes were better with HMA venetoclax compared to the HMA monotherapy alone. And you could see that the post-transplant and the blast 10 to 19% and TP53 wild type, ASXL1 mutated, they were all very sensitive to treatment with HMA venetoclax, and all of them attained statistical significance. So what is the next role for what is the next step for BCL2 inhibition in higher risk MDS? So this is lisaftoclax. This is a next generation BCL2 inhibitor that is being evaluated in patients with higher risk MDS. So this phase 1b2 study combines lisaftoclax with azacitidine in patients with newly diagnosed or previously venetoclax exposed myeloid malignancies, including higher risk MDS. The primary endpoints for phase 1 was a safety, tolerability, and DLT, and to identify the recommended phase 2 dose. And for the primary endpoints for phase 2 were efficacy of this AZA with lisaftoclax in AML, MPAL, chronic myelomonocytic leukemia, and higher risk MDS. Lisaftoclax with azacitidine was active and well tolerated in patients with high-risk MDS and other myeloid malignancies. As you can see, the overall response rate, this stacked bar plot shows those patients who were relapsed refractory to venetoclax. That means they have already been exposed to venetoclax. The overall response rate in this population was 31.8%. with a CR/CRi of close to 22.8%. The AE profile was sort of similar to the HMA venetoclax arm, so it's about in about 70% of the patients with AML-MPAL and about 60% with MDS-CMML. Febrile neutropenia was noted in about 30% in AML-MPAL and 20% with MDS-CMML. So this is the updated abstract that is being presented as a poster in this ASH. This is for just high-risk MDS and CMML. This is about 15 patients. And the overall response rate in this population is 80 with equal responses for equal rates of response for both complete remission and marrow CR. Lisaftoclax may potentially overcome the venetoclax resistance in the venetoclax-exposed patients with myeloid malignancies. So this is the ongoing phase 3 GLORA-4 trial. This is assessing the lisaftoclax with azacitidine in higher-risk MDS. There are some unique aspects of this study. Patients with newly diagnosed high-risk MDS are randomized to both lisaftoclax and azacitidine arm and the aza monotherapy arm. So the primary endpoints, there are two co-primary endpoints to this study, the rates of complete remission and overall survival. The responses are assessed based on the new IWG 2023 criteria, and the secondary endpoint would be safety evaluation. So what are the take-home from Verona and future directions with BCL2 inhibitor? And do I still use a HMA venetoclax combination in these patients? Absolutely. So in the Verona trial in high-risk MDS, the primary endpoint was not met, which is a disappointment. However, this population also included patients with low blast, TP53, and significant use of stem cell transplant. We should keep in mind that the VLA was positive because most of that was evaluated in transplant-ineligible population. So almost all the patients were enrolled were 75 years and older. There were only like a fraction of the patients who went to transplant. So that is the significant use of stem cell transplant probably played a role here as well, because most patients on both arms, which is the aza monotherapy as well as the aza-ven combination arm, did go to transplant. A higher proportion of patients treated with ven-aza achieved higher response rate and marrow CR with hematological improvement, and numerically lower risk of AML transformation as opposed to those treated in the aza monotherapy arm. The subgroup analysis did show favorable trends in response for venetoclax and azacitidine in younger patients, patients with excess blasts, and select mutations such as ASXL1, splicing factor mutations. As we already know, additional therapies are needed direly to treat newly diagnosed patients or prior ven-exposed myeloid malignancies such as MDS, and GLORA-4, which evaluates the newer generation of BCL2 inhibitor, is open and actively enrolling in the United States. Thank you.
Thank you, Dr. Venopal. I think we have some time for questions. So let's start with the first one. So do you change your management if treating a patient with low-risk MDS but EPO level around 500? So what is your take on this, Maria?
The first question is transfusion dependent or not? Probably with this value of endogenous EPO level, the patient is not going to respond to ESA, so this not be a very good option, especially if the patient is also in transfusion dependency, and probably we should treat with luspatercept or even imetelstat. It depends on the availability of the drug in this context. In Europe nowadays, we don't have access sometimes to luspatercept in ring sideroblast negative patients, but we also don't have imetelstat. So theoretically, we cannot treat this patient with more than ESA, but ideally, probably if available, we should choose first luspa, and if the patient did not respond or lose the response, move to imetelstat. The idea is to try to keep the patient in the most of the time in the transfusion independency and not exclude for different drugs available. So probably choose first the low toxic drugs like luspatercept, and after that move to another more severe regarding adverse event drugs.
Thank you. The next question is actually quite interesting. Maybe Sangeeta, you can address this. So you are looking at a patient with low-risk MDS. You do your bone marrow test. Now you have a diagnosis, so low blast. Do you wait for the NGS or do you start right away?
I start right away, but if we have clinical trials, especially some of these subset of patients may have IDH2 or IDH1. So in our centers, we do have some of the clinical trials that are exploring the role of IDH1 and IDH1 inhibitors in lower risk MDS. So in that case, I would wait. But if this is not an option that is available in our center, then I would not wait for the NGS results. I would start treatment.
The next question actually may be more than a question, maybe for Maria, because we didn't really talk about new drugs and things like that. So the colleague is saying, with so many agents being investigated in clinical trials right now, what is the role of ESA therapy, etc.? But the reality is that we didn't have an opportunity to discuss other clinical trials. You want to tell us, Maria, what's going on, because you are the leader on many of these studies, so this is maybe a good opportunity.
I think that the more advanced drug nowadays is elritercept, a novel TGF-beta inhibitor. Is currently on phase 3 trial, similar to the medalist design for luspa-naive patients, and is probably a more potent compound regarding TGF-beta inhibitors. And regarding another clinical trials in which we are participating, I think this is also of interest, and you are going to present some results about IRAK1 and 4 inhibitors. I think this is the role of the most advanced. And regarding the role of ESA, at least in Europe, until the results of ELEMENT trials, we use erythropoietin stimulating agents very early at the initiation of the anemia, when the patient is in the non-transfusion dependent setting, because we think that in this phase of the disease, the drug is very effective, very safe, and can achieve a very prolonged period of time without transfusion. ELEMENT trial is now addressing if it is better for this purpose, EPO or luspatercept. We don't know, but I think that the mission is nowadays at least ESA are available in this setting.
Thank you, Maria. I think we can go, there's some other studies like ongoing. So we talk about the elritercept, we talk about IRAK4 inhibitors. There's also this kind of inflammasome inhibitors like the NLP3 inhibitor. There is actually some data that's going to be presented maybe with the low-dose oral hypomethylating agents. And then interestingly, momelotinib, that is this drug for myelofibrosis, also there. So we have a lot of movement in low-risk MDS. So we need a little bit more in high-risk MDS, but we saw the data with the next-gen BCL2 inhibitor, lisaftoklax, from Dr. Benagupal. And there is one more question. I don't see anybody on the floor asking, so this is also for Dr. Benagupal. And it goes back to this issue of the mutational profile. So when do you consider a stem cell transplant in a patient with low-risk MDS? Is there a role at all for transplantation in low-risk MDS patients?
Yes. So if the patient has a higher mutational burden, so several studies have shown that the number of mutations in MDS or lower risk MDS is prognostic. So if the patient has more than 2 mutations, so they are at a higher risk for transformation to AML. And nevertheless, whether the patient is ready for transplant or not, we always evaluate the patient for stem cell transplant. And if and when the patient needs it, then the patient goes for it.
So going back to the first question, so you had the patient, you do your NGS, you don't wait because you're not really going to act on it. But later on, depending on response to ESA or luspatercept or imetelstat, if they have a high molecular burden, and if it's younger, maybe there will be a consideration for. Excellent. I think that covers all the questions that I have here in the iPad. So I'm super grateful for you guys coming here. I think there is actually some people maybe online. This is a great opportunity. Thank you for the organizers for putting all this together. And we wish you the best as possible. Thank you very much for the opportunity. And thank you, Maria and Sangeeta, for your talks. Thank you.
Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and by the European Board for Accreditation in Hematology. This activity is developed with our educational partner, the HealthTree Foundation for Myelodysplastic Syndromes. This activity is supported through educational grants from Ascentage Pharma, Bristol Myers Squibb, and Geron. To access all materials for this activity, visit peerview.com/GKY860.